Good morning or good afternoon, wherever you are. Um, I'm really pleased to present uh, about the product called VASH, which contains pure hypochlorous acid as a preservative in the wound cleanser. And I'm going to discuss, along with my esteemed presenters, why it is the treatment to improve the healing outcome of lower limb wounds. Next slide, please. This particular product has a lot of science behind it, but more important, or as important as the science, are the clinical results. And today, the presentation will be led by Jeremy Caul, who works in the rather inaccessible corners of Canada, and he's a clinical nurse practice with many years of wound treatment experience. He's going to share some quite remarkable cases of how wounds can be managed in a remote location with VASH. We also have Amanda Loney, who is an NSOC from the Greater Toronto area, very experienced, and it's a real privilege to talk to both of them, who will be presenting the clinical cases around VASH. My name is Debashish Chakravarti. I'm a chemist by training, and I will be present for the question and answer session to answer any scientific or chemistry related questions that you may have. I want to thank you for being present on behalf of URGO Medical North America, and I will now request my esteemed clinician colleagues to start their clinical presentation. Thank you.
Hi, everyone. I'm Jeremy Caul. I'm a registered nurse here in Sioux Lookout, in remote Northwestern Ontario, and I'm here to present a few case studies of my use with VASH. So I just want to tell you a few speaking points on VASH and the science behind it. Pure hypochlorous acid is a natural molecule. It has a pH of 3.5 to 5.5. The pH helps wound healing, and VASH is held tightly in that range over its shelf life. The URGO-Med's been able to procure a method of actually stabilizing the molecule long term. The acidic pH is also hostile to pathogens and biofilm, but pathogens thrive in an alkaline pH. So we're going to talk a little bit about how important it is to balance the acidity of your wound. Pure hypochlorous acid cleanser, or VASH, is non-cytotoxic to tissue. Other cleansers without pHA may be cytotoxic, particularly if they contain hypochlorite, which is present in Dakin solution. At a pH above 5.5, pure hypochlorous acid can't exist. So that higher pH is closer to pure hypochlorous acid is converted to hypochlorite, the toxic agent in Dakins. So once the pH rises to that point, then it becomes more cytotoxic. Hypochlorous acid can remove biofilms, and wound pH change is a gradual process. The wound bed changes slowly over time using something called surface effect. So don't expect VASH to change your wound bed pH right away. The problems at the surface take a little bit of time to resolve. So the acidic cleanser VASH will gradually turn the wound acidic, and there's no approved or easy way to measure wound pH. We have to depend on research to come to our own conclusions. The body finds hypochlorous acid at 300 parts per million, and that's what's present in VASH. Because it creates the same molecule to kill germs that invade tissue, it's managed by the tissue protective systems that keep hypochlorous acid toxicity low. The same sort of protective system for other cleanser preservatives such as PHMB, CHG, or hypochlorite. So what you see here is the natural occurrence of hypochlorous acid. When your white blood cells or your neutrophils form around an organism, they produce hypochlorous acid at this concentration. So VASH has found a way to make it as close to what the body already produces. And we know that VASH stimulates fibroblast and other helper cells to proliferate and do what they do best. In this study, it shows that VASH is able to penetrate and remove biofilm that's 24 to 48 hours old, as compared to this antimicrobial here. Over a period of minutes, VASH can kill biofilm in MRSA, E. coli, and Candida albicans, reducing them to more than 4 logs in a matter of minutes. But some places want to use sulfamylon or mafenide acetate, but that does not penetrate biofilm at all, as seen in the lower panel. The treated line and the control line fall on each other. There is not even 1 log reduction of germs in most cases. So VASH currently has the highest concentration of hypochlorous acid. Some salient points on VASH. It currently has the highest amount of pure hypochlorous acid preservative. Its pH tightly controlled between 3.5 and 5.5 is the sweet spot where hypochlorous acid is uncontaminated by any hypochlorite anion or anion that is toxic. But keeping hypochlorous acid pure so that its solution is least toxic to tissue requires tight pH control. VASH has achieved this using a special formulation techniques and electrochemical manufacturing process. Such is the nature of hypochlorous acid hypochlorite equilibrium as seen in this image. In the graph, the blue line shows the hypochlorous acid concentration reduces the pH of the solution going from 5.5 to 10 if one sees the right side of the graph. This is true for products whose pH is from 5.5 to 7 anytime during their storage, and shown in the red oval where the blue line has started to dip and the hypochlorous is falling. And the gray line has started to rise. The hypochlorite has started to rise in presence. The proportion of hypochlorite and therefore cytotoxicity increases as pH increases. At pH 9 and above, all the hypochlorous acid has been converted to hypochlorite and the solution begins to look more like Dakin's. So the stability of the product is very important. Now, the consensus guideline developed in 2022 is an addition to additional periodically created guidelines that inform the wound healing community. This paper in particular has just been published in the prestigious Journal of Wound Repair and Generation. It recommends the use of hypochlorous acid-based cleansers due to the high margin of safety for the product. For mainly evolutionary reasons, hypochlorous acid is far less toxic to wound cells as compared to germs. This is generally not true for other preservatives, in that if they were too effective at killing germs, they're also sometimes effective at killing cells required for healing. This is certainly true of Dakin's, which is a known cytotoxic agent. Use of pure hypochlorous acid to address biofilm using non-cytotoxic topical antimicrobials promotes the body's natural inflammatory and immune responses in keratinocytes and fibroblast migration and their replication rates. So a little bit of background and context to where I provide care. In remote and isolated Northwestern Ontario, our population suffers with the highest rates of amputation in the province. There are numerous geographical and socioeconomic barriers that dictate service delivery and health outcomes. In that context, keep in mind that the following cases outline care not fully meeting evidence-based practices that limit healing capabilities, but are still able to highlight some of the evidence for VASH used in our region. My first case is a 49-year-old male with diabetes, obesity, and he's living with a venous leg ulcer. He's an Indigenous man from a remote northern community who suffers with mobility limitations and has had numerous injuries that led to development of a chronic venous leg ulcer. I started working with him in June of 2021, and I had not really experienced VASH at this point. The patient said he had first noticed the wound over a year ago, so definitely an old chronic wound. It healed once and had been currently reopened for about 3 months. The only real history I received from the nursing station was that he had several short courses of antibiotics in the past for various signs and symptoms of chronic wound infection. His swabs were always positive for typical chronic wound bacteria and Pseudomonas. We don't have a lot of resources available in our area, so when the nurse in charge reached out to me, they had been using a 1 to 5 acetic acid water acetic acid and water solution and serial debridement to try and improve the tissue quality, but it was a struggle to get the patient to adhere to the treatment plan. I recommended an antimicrobial dressing that they had readily available and suggested an urgent infectious disease consultation to guide the treatment of the chronic infection. My next follow-up was almost a month later, and due to challenges with telemedicine access in the community, the wound had deteriorated. The infectious disease consult had not taken place yet. It took until September for the patient to be flown out of his community, as he had signs and symptoms of infection and finally overcome the nursing station's ability to manage it, and he had to come out. He was immediately treated with IV antibiotics and remained on treatment as an outpatient for 6 weeks. Now, at this point, my fabulous rep Lee convinced me to give VASH a trial, and she had sent me some supplies to get started. She also helped me find that VASH was covered by NIHB, the federal insurer for Indigenous patients across Canada, except in BC. I implemented VASH compresses and provided the patient in the nursing station with an adequate supply. I also ensured that the patient was in adequate compression and that he had a supply of that. The patient had a preference for his antimicrobial dressing, and he couldn't be convinced otherwise, so we obliged. The patient's a medical van driver in his community and also is married and has children. He speaks highly of himself as a busy man with limited attention paid to his own needs. As such, it was really challenging for the nursing station to get him tied down long enough to do a dressing change some weeks. So he either had dressings on for too long or none at all from time to time. From October to November, you see the wound deteriorate. After my wound follow-up and a replenishment of his supplies, his wound began to make progress again. I didn't get to follow up with him for over a month, or he didn't get to follow up with him rather for the month of December and January due to community shutdowns, COVID restrictions, and limiting follow-up and availability. But despite the patient's barriers to adherence, his access to continuous supplies and treatment for compression and other dressing supplies, he was able to be maintained without any further antibiotics. It may be hard to tell in this last photo, but those are epithelial islands amongst the drainage that hasn't been cleansed away. And it's too bad the nursing station didn't do a VASH compress before sending me this picture, but I believe it highlights that the wound is overall improving. Keep in mind that his biggest complaint was, in the beginning, was the malodorous discharge. His favorite feature of the hypochlorous acid was its ability to rid his life of the rancid smell of serous drainage and chronic infection. A massive but hidden benefit was that the patient remained in his home community where he prefers to be from September to present without needing any further antibiotic treatment nor further medevac out of the community, all despite huge personal, geographical, and systematic barriers to health. And he continues to make progress. My second case is a 64-year-old Indigenous male with diabetes and a history of stroke with left-sided weakness. This gentleman developed an ulcer to his weaker foot that quickly progressed to osteomyelitis and ultimately required amputation of his 5th digit. I met him on July 7th, 2021, when he self-referred with a mostly dry necrotic wound only 6 days post-amputation. He was sent home with inadequate offloading and limited antimicrobials. After several weeks of outpatient IV antibiotics and VASH compresses, where the wound was optimized for negative pressure, meaning that we had produced enough healthy tissue to warrant treatment with a negative pressure dressing. And it does have its limitations in our area with lack of experience and trained nurses to manage, but despite our best efforts, the bone was still compromised and further revision of his 4th digit was required. With negative pressure, we didn't have the option to use installation, so we got a little creative with intermittent settings and VASH compresses with each dressing change. And it was effective at reducing the bulk of the wound surface area and improving the tissue quality. Now, keep in mind that the patient had a number of barriers to offloading. He used a removable cast walker only at home for fear of safety outside the home with his left-sided weakness and the icy, slushy conditions of our region at the time. Now, I don't have the most recent updated photo actually shows a wound surface area of about less than 1 centimeter squared. His wound is almost completely cleared up. We stopped about after October 21st, he gave up on the negative pressure, and he was tired of carrying around the device and some other factors. But ultimately, we continued with the pHA compresses, and he did not succumb to another infection after that. My third and final case is a 65-year-old Indigenous man with diabetes who suffered a traumatic injury, and he figured he would heal it on his own. Unfortunately, it quickly became infected, requiring oral antibiotics. He had 2 days of IV antibiotics to gain control of the infection. And notice the difference between February 15th and March 4th. This was the time that pHA was implemented. In less than 3 weeks, the wound went from almost 100% fibrous slough to almost 100% healthy granulation. This patient had some evidence of venous stasis and was able to obtain some very mild compression along with standard wound care plus the pHA compresses. This patient was lost to follow-up as he is back at his busy traditional lifestyle, and word is that his wound is completely closed now. So very, very good success with that one. So in conclusion, pHA boosts natural immune response. We know that pHA is safe and non-cytotoxic, and we know that pHA is covered by non-insured health benefits. To me, this is a no-brainer. Over the standard irrigation solutions, we have patients who suffer at high rates of limb loss, infections, diabetes, and other immune compromise at a very young age compared to the rest of the population. I personally order pHA for nearly every patient. Thank you for your time, and I'm going to pass it over to Amanda now, who's going to talk a little bit more about pHA and her experience.
Hi, my name is Amanda Loney. I am a certified nurse specialized in wound, ostomy, and continence, working for Bayshore Home Care Solutions. I am here to share some of my experiences with pHA wound care solution, and I hope that I can share some of the science behind why I have kind of made the decision to make that my #1 go-to product. So the buzzwords around wound care solutions have been increasing over the past few years. We seem to kind of get on different buzzwords, and one of the buzzwords right now is wound hygiene. And I think when we see of how we can all optimize our wound bed to make it, improve it, wound hygiene is just one of those things that we need to be looking at when we're looking at healing our wounds. So most available options force you to compromise. You know, you want to find the right balance of competing factors between products currently available. For wound cleansing can be really challenging out there. And to be honest, I've been using wound care solutions now for quite some time, and I've always been using the ones that just come to me, whatever the patient can get their hands on, whichever one they can purchase easiest, whichever one I get samples of. And so I've been a big advocate of wound care solutions, and I've been seeing some good benefits from that, and that's why I've been using them. But up until just very recently, I have now kind of narrowed it down onto the different aspects and what wound care solutions have better qualities and ones you should be looking for. So often when you're looking at, you want a safe wound care solution, but you want one that's actually going to be really effective with wound care healing, and there's a balance between that. So what if we didn't actually have to compromise between a safe wound care solution and one that actually was really effective at killing bacteria? So when we look at our own body, we have innate immunity, one of the most powerful phenomena on the planet, and we're living proof of it. So when you look at how our bodies actually adapt to killing off bacteria, you look at the pathogen is targeted by chemotaxis. So then you get this neutrophil that creates a pseudopod to engulf the pathogen, and the neutrophil then forms a phagosome, which surrounds the pathogen. So this is where you get the hypochlorous acid is generated within our own bodies to actually kill the pathogen. Okay, so the hypochlorous acid is what actually kills that pathogen, and then it's excreted. So bacteria is being overtaken by the neutrophil, and then the hypochlorous acid within the neutrophil kills it, and then it's gone. So pHA wound care solution contains 0.033% hypochlorous acid as an antimicrobial preservative. So now you got to think about, okay, I've got my wound bed. My body creates this to kill bacteria, but what if I can actually add this within my wound care products? Would this not help kill bacteria on the surface and improve my wound healing? So my first case study is pyoderma gangrenosum. These cases are extremely difficult to deal with. They've got so many things going on. This lady that came to me was gifted to me by another wound care consultant and a couple other wound care physicians who were trying to deal with this lady. She had a 5-year history of these wounds. This wound actually being consistent. She had other previous wounds that kind of had healed up. This one was consistent. My first assessment of her was in August of 2020. She had a right lower leg ulcers. The ulcers started from the lateral side of her leg. They wrapped around to the back of the calf and then back around to the medial side. So you can see the photos. The one on the top left is the back of the calf. The one on the top right is her lateral leg, and the bottom is the medial aspect. These wounds are extremely painful. And she had been on and off antibiotics throughout the year. She was pretty much almost constantly on them. So treatment was initiated August of 2020. And I have to tell you, when I get patients that have had such long chronic wounds that are extremely painful, my first job, I think my first goal is to kind of gain the trust of the patient. So I don't want to change too much at once, because they've already been through a lot, and they're really quite skeptical, and things have caused them massive amounts of pain in the past. So the treatment that I actually started for her, the only thing that we did different was she was already using an antiseptic soak. Within my agency, we were using them. I was a big proponent of them. I wanted everyone to use them, so we were using them kind of sporadically for those troubled patients. And I did start her on the Protopic and the Santal for wound debridement, because this would be way too painful to be debriding with the scalpel at this time. And my other goal for her was to get her into some compression. And pain was a huge issue, and I think kind of dealing with that pain to try and get into the compression was also one of the things that we were looking at. She did trial some steroid injections, but not kind of as aggressively as I would have normally liked for her. And she didn't really want to go back to that again. So you can see on the right-hand side, that was my treatment plan there. So jumping ahead, so August 2021, so 1 year later, we can see this lady's wound, and she's progressed really nicely. So now this wound is in two wounds. It doesn't wrap around to the back anymore. The top wound is the lateral aspect. The bottom is the medial aspect. So we've made some significant improvements. She's definitely decreased her antibiotic usage. Typically right now she's on them about, at that time she was on them about every 2 to 3 months. She would have to go on and do a repeat dose. She was able to tolerate compression, so we got her into some compression, but the drainage was still high. She was requiring 2 Q2-day drain dressing changes related to the high output. And if you take a look at that wound bed, it's extremely unhealthy looking. It's got that dusky gray kind of look to it. There's nothing really healthy looking about it. But surprisingly, we were actually making some headway with healing. So that was good, but it was slow. So when you take a look at this wound and I'm saying, okay, I'm making some slow progress, what can I do to try and help kind of speed this up for her a little bit and maybe decrease her pain as well? So what are the things that you're going to try and optimize for your wound bed? So typically what I always think about when I'm looking at these patients is you always want to address your underlying disease process or the reason for the wound. So we had to address her disease. So we did give her steroids. She was on steroid therapy, and she was on the tacrolimus, and we got her on the compression to deal with the swelling. Pain management was an ongoing thing that we were trying to deal with, and we're still trying to deal with. Debridement, we started her on the Santal because again, the compression was too much. Sorry, the sharp debridement would have been too much at that time. But as the year goes on, you can see that I was able to do really, really light conservative debridement for her, very, very light. But when you're looking at now optimizing your wound healing, so the factors we looked at, we talked about and addressing the underlying disease process, and then giving good wound care. But I'd never thought about part of giving my good wound care would be to address my pH of the wound. And so now this is something that crosses my mind when I'm thinking about wound care, how to address the pH of a wound. And I know that in the past, there had been tests that I remember getting these little test strips to test the pH of a wound to find out if the wound was in a chronic state or in a healing state. And so we know that pH is directly linked to healing wounds. That's kind of science that we all know about. So when you look at wound progression, as chronic wounds heal, there is a significant decrease in the wound pH. So when they're high, the wound is stalled. And when they start to get low, back around the intact skin, we're getting good healing, we're getting wound healing. So protease activity and oxygen release reduce toxicity of bacteria and products. And this is as the wound progresses through the healing stage. Enhanced destruction of abnormal collagen and angiogenesis. Increased macrophage and fibroblast activity and control of enzyme activity. So wound pH and wound healing are related, and we see that slide there. And if we take a look at our other wound care solutions that may be addressing some of our bacteria a little bit, we're not actually creating an environment for wound healing. pHA sits in that intact, you can see it sits in that intact skin in pH balance. And that's what we want to do for wound healing, get it to that. So chasing your tail, what happens when a cleanser pushes the pH to alkaline levels? So when you look at pH of a wound bed, and you're thinking, so why is it that if we have a higher pH, our wounds aren't healing? Well, one of the factors that gets them in that chronic state is that microorganisms like high pH. So if we have a higher pH somewhere around 6, 7, you can see that the optimal pH for growth of the most prevalent microorganisms is on the higher side. So 7, 8, 9, that's where all of our microorganisms are going to grow. So if we can lower the pH, we're going to decrease the likability of our wound environment for bacteria to grow. So the pH and making the wound environment acidic could benefit the healing process. We're going to make the environment great for wound healing, not good for bacterial growth. Increased pH increases biofilm. So decreased pHs decreases the likelihood of a biofilm forming. When we get back to the case study here, so we're jumping ahead now. So now we're in February the 28th, 2022. We had been starting to use pHA. And to be honest, I didn't make that a conscious choice at the time as this was my solution of choice, but rather this is what we had available to us. So we now had a steady supply of this particular wound cleanser, and we had been using it for quite some time. And you can see that the wound bed compared to previous is looking really healthy. We're seeing it red, healthy granulating. It looks great. So she came in to see me in February, and I took that photo. And then when you take a look at the photo in April the 11th, 6 weeks later, she came in to see me again. And I'm looking at this wound and I'm thinking, oh, this doesn't look as good anymore. It's got that dusky tone to it and it doesn't look great. So I was kind of at a loss as to what was happening because we didn't change any of her dressing treatments. I didn't want to start her on antibiotics because when I think about it and I look back, she wasn't really tolerating the antibiotics that well anymore. It didn't make her feel very well, but she hadn't been on antibiotics for quite some time. So kind of being the, I don't know, wound geek that I am. So I go home and I'm kind of racking my brain. And when I'm writing up her consult note, I like to take a photo and I like to zoom in. I like to look at my wounds kind of microscopically. And I can't do that in the clinic setting or in the home setting, but I can do it at home when I zoom right in with my pictures. So I've kind of like zoomed into these photos, and you can tell in February the 28th, you can see some really good epithelial tissue kind of around in that blue circle there. And when I look over at April the 11th, I can see that my epithelial has decreased. So the wound bed no longer looks as healthy, and the actual epithelial tissue is less. The patient, and when I spoke to the patient, she had talked to me about that she had a slight increase in odor and there was some more drainage happening. And I'm thinking, oh gosh, is she getting an infection? But I didn't want to give her or jump on the bandwagon of antibiotics just yet. So she had brought in another antiseptic soak, and she had asked me, she told me that she'd been using it. And she said, is it okay if I use this up? Because I had a bottle still around. And I'm like, sure, go ahead, use it up. But when I got home and I took a look and I thought, okay, this is the one thing that we had changed, and I could see a real substantial difference in our wound bed. So I called her back up and I said, you know what, I want you to switch back to just using pHA. And this was actually after I started doing some research around pHA, and I said, let me see if this actually makes a difference. So I asked her to switch back to using pHA, and you can see right here, a couple dressing changes later with pHA, no other changes made with her treatment. You can see that the wound bed starting to look healthier. I mean, it's not looking as great yet, but we're only talking about a couple dressing changes later, but definitely looking healthier. We see less of that gray tissue, and it's starting to look beefy again, and we're starting to see some new epithelial growth again. So was really happy and pleased to see that turnaround and not having to use that antibiotic. And I know when you take a look at her wound, when you see that kind of inflammation to the lower the ankle there, that has been chronic for her all along. So that is not kind of a sign for infection for her. So my next case study, this is a gentleman, an 80-year-old gentleman, and he came to see me. He was a patient of mine in the past, and he came to see me. He had a history of a Charcot foot. He doesn't have any pain, and hence he walks on it. But he had gone and gotten some new orthotics, and this was at my request because his old orthotics, we just healed up a wound, and I said he needed to go get his orthotics adjusted so that this wound wouldn't break open in the arch of his foot that we had just healed. So he went and got some new orthotics, he went and got some new shoes, which is great. And then a few months later, he comes back into the clinic, and this is the way he presents. And I'm like, oh, what happened? And he's like, oh, I got these new orthotics. And so he presents with this in the clinic. So you can see that he's got some infection. You can see the toe is red and swollen. So we started him on some antibiotics. We wanted to treat the deep tissue infection. And so we did that. And then we're going to treat topically. So the first thing that everybody kind of puts on these types of wounds is betadine. So everybody kind of, that's still kind of a go-to. So betadine was initiated. We were doing a 5 to 10 minute soak with betadine, and we were using a longer acting antimicrobial between dressing changes because betadine is very, very short-lived with regards to its antimicrobial activity. And we strongly encouraged to limit walking. So coming back in, so now he's coming back in and it's January. So not that far past the original time. And you can see that, sorry, this is actually February the 10th. I think I might got my dates mixed up here. But he came back in and it's gone really bad. And I'm thinking, what happened? So he had his orthotics adjusted. He bought new shoes. And instead of a men's shoe, they gave him a woman's shoe. And he was jamming his foot inside the woman's shoe. And he had his orthotics adjusted to fit the woman's shoe that was too small. So now he's come back in and he's got this big stage 4 ulcer, big piece of bone sticking out of there. And so it's not looking good. So the nurse sees this and sends him off to get the infection under control. She thinks that now that there's bone showing, that she wants to start him on IV antibiotics. So the first thought is stabilize the wounds. When you're dealing with these types of wounds, you want to stabilize the wounds. So she sends him into the ER. They started IV antibiotics. His orders were February the 8th to March the 20th to do these antibiotics. So blood flow, this goes through my mind. Is he able to heal this? Does he have enough blood flow? Is he going to require an amputation? Debridement, what are we going to do for debridement? Am I going to use sharp? autolytic, enzymatic, mechanical, and the dressings. What are we going to do for his dressings? So the first thing I do is I want to remove all the necrotic tissue that I possibly can. So this is great because he doesn't really have feeling in his toes, so the pain isn't going to be an issue. So I removed the big chunk of bone there, and I took away all of the sloughy tissue that I could find. So this left him with a nice hole in his foot. I could still see the bone down below. So I'm thinking that this is going to be infected. And so I referred to a specialist in foot, in the diabetic foot. Although he's not diabetic, he's still a foot specialist. So I referred to Dr. Meyer to remove the rest of the bone. So I called him up and said, hey, I'm sending you somebody, take a look. One of the big things I can say that when you're looking at treating wounds is having that team available to you is so important, to have everybody that infectious disease, somebody who can do sharp debridement, someone who's willing to do bone amputations if you need it. Having somebody on board with that is makes wound care treatment much easier. So we now needed to treat topically. So what was I going to use to treat topically? We've got the systemic part under control. And again, so he comes back from the ER and the orders are to pack it with betadine. We took out the bone. He's on IV antibiotics. And betadine is not my first choice. It kind of turns into this hard ball and it causes even more pressure. And again, the antimicrobial doesn't last very long. So again, when you're looking at trying to treat and provide the optimum wound bed, what can you do? So now we actually wanted to look at how can I treat to get good moisture balance, good bacterial balance, and as well now I'm thinking about pH balance. Okay, so this is what we did. We started him with a Vashi soak, 5 to 10 minutes. We treated the infection topically as well as systemically. We optimized the pH for tissue growth. We optimized the pH for decreased bacterial growth as well. So we're decreasing the chances of biofilm growing. And this is what we did for the soak. You can see the huge improvements with the wound healing here. And then between dressing changes, we would fluff in a silver calcium alginate. This would create good absorption because we don't want to create a lot of maceration happening. It's also not too bulky because he was still shoving his foot in his shoe with his orthotic to walk. And it wouldn't create too much more pressure for that. And when you take a look at the outcomes of this, so February the 10th, to February the 24th. That's pretty impressive for a gentleman who's quite elderly. And we did stop his IV as soon as he went to go see the physician to remove the rest of the bone. He stopped the IV, he continued on oral antibiotics for a short period of time afterwards. And just to give you a heads up, this gentleman actually went on to close quite quickly. So really impressed with that. Next case study, I got a call from a nurse and she showed me a picture of this lady. Her wound was originally all black eschar on there. And then she called and said, oh, you know, the eschar is starting to lift. It's starting to get, you know, purulence kind of draining from it. She had bilateral lower leg swelling, diabetic, coronary heart failure, dementia. She was removing the dressings all the time. They were painful. So despite the painting and just a dry dressing on her wound, it did start to break down. So I got a call 11 days after that initial photo, and you can see that it's all broken down right now. The wound is increased in size, 5 by 5 centimeters, and we're getting large cerebropurulent drainage there. And you can see within that dressing, there's even that green tinge, and the odor was definitely a Pseudomonas. And what do we do for a Pseudomonas? Well, we treat with acetic acid. So they started with acetic acid soak, and they were using an antimicrobial dressing, and they were doing daily dressing changes again because she was removing the dressing and there was a huge amount of drainage, and you can see the maceration within this picture. So this is what you can see that was going on. She was, and this is April the 12th, so 6 days later after the last picture. So I go in to see her. It's too painful to do any type of debridement, so I couldn't do any sharp debridement for her. And so the only thing that I actually did for her, so this is 2 weeks with a pHA soak. So I continued with the exact same treatment, and I stopped the acetic acid and I started a pHA soak. So Pseudomonas cleared. So actually it was only in a few days after we started that soak that the nurse called and said, hey, the Pseudomonas has cleared, our drainage has decreased, and we were able to decrease her dressing frequencies because the patient was now keeping her dressings on. And the surface area here, you can actually see within that period, so 2 weeks, we got a 46% decrease in size. Now, probably some of that was the swelling in the foot kind of coming down, but you can see that granular tissue starting to happen to the wound bed. So super impressed there. This was pHA instead of acetic acid. I'm not saying that that's what you should do, but my finding was this is what I got great results with it. I would love to see kind of head-to-head studies done on this in the future to see whether this is actually more effective or whether it's really effective at creating a better wound environment for your own body to help healing and get rid of that Pseudomonas. Next case study. So again, this was a case that got transferred to me as a wound consultant that was seeing her previously for years and years, was retiring. So I got this lady as a transfer to me. This was in September the 9th, 2021. She has lymphedema there, chronic ulcers following leg necrotizing fasciitis, failed skin graft, multiple cellulitis bouts each year. In fact, when I saw her, she says, hey, do I need antibiotics? I've got a standby. That she was chronically on and off antibiotics for years. They did do a trial of negative pressure on her. They did a gecko trial, and they were doing, at the time that she was coming to see me, again, they were using an antiseptic cleanser and doing a soak with that. So this is what I was looking at, and you can see that her wound bed, when you take a good look at it, is not looking healthy. Right lateral, this is the largest wound, the right lateral wound. And so we did some sharp debridement there. And you can see the peri wound had some slight inflammation, and the drainage was moderate to large seropurulent. She was requiring dressing changes quite frequently, every 2 days, every 1 to 2 days, related to the drainage. So when you're looking at your antimicrobial or your wound care solutions to help clean, most available options kind of force you to compromise. Finding the right balance of competing factors between products currently available for wound cleansing can be very challenging. So you're looking at, you want that kill factor, you want to kill all your bacteria, but you also want to create an environment that is good and healthy for your fibroblasts, for your epithelialization to happen. So you don't want to be killing any of that aspect off and create a cytotoxic environment, but you want to create the best environment possible. So when you look at the graph, you can see the relative cell viability. pHA's got the highest by far. So that's really important when you're looking at trying to create an environment for healing. You don't want to be killing healthy cells. Granted, when the wound is actively infected and it's deteriorating, your biggest thing is to stabilize the wound, and you're not kind of trying to think about, okay, the wound's healing, but you're actually looking at trying to stabilize it and preventing it from deteriorating. But now I'm thinking, if you can actually stabilize it and create an environment for healing, I think that you're getting the benefits of both that safety and the efficacy of a great wound cleanser. When the safest or non-preserved options are used, patients are not proactively protecting from predisposing risk of infection. So when you're using those wound cleansers, some of them you're not actually, or you're using your standard wound care solutions such as saline to cleanse a wound, you're not actively kind of proactively protecting yourself from bacteria. When you cleanse the wound, that definitely helps versus not cleansing at all. We know that. But if you can go above and beyond that and create an environment to decrease the risk of biofilms forming and bacteria from growing, that would be optimum. So when some cytotoxic traditional options are used, such as Dakins, even with dilution, patients could end up sacrificing key cells necessary to promote healing of skin and wound closure. And this can be really vital for those people that are really struggling to heal their wounds related to some underlying conditions that they may have. So taking a look at this wound right here, our treatment plan for her was to cleanse the wound bed with normal saline, patient to remove all the dressings and shower, and we applied a soak with pHA for 10 minutes. So I didn't actually change a lot for her at this moment. The only thing I changed was I added an actual pHA soak to her. And we were using Hydrofair Blue Classic. This was going to help with some of the debridement in between. We covered with Mesorb for absorption, and we initiated, well, she actually already was in compression, but we did initiate a different type of compression for her. And we actually taught her to do her own compression so that she could change her dressings really frequently. So 18 days later, when she come back in, she was really happy. She was kind of astounded that the wound bed, and she was a little kind of freaked out. She actually wasn't sure if it was a good thing or not, because she had never really seen her wound bed look really nice and beefy red and granular. So 18 days later, and now we have a healthy wound bed. November the 15th, 2021, you can see just how much this wound is healing, and we're not changing much of anything. Again, just we're using that pHA soak. She's doing it, and it looks fantastic. So outcomes following 8 months. A significant decrease in drainage, decreased frequency of dressing changes to every 3 to 5 days. So now she can put on her compression and she doesn't have to take it off and change it every 2 days, which is a big imposition for her, considering she was doing her own changes. And this isn't a young woman. And so for her to get down there and do her own compression wraps and dressings, it's very time consuming for her. And she did a fabulous job. So we started her with the pHA. She did the pHA soak. She showered, did the pHA soak. From the time we started that soak, she had not required any antibiotics. So this was the first time that she went 8 months without antibiotics. And that was huge for her too. She actually said that she threw out her standby antibiotics for the first time because they were kind of expired. They had sat there for so long. So she was extremely thrilled with that. pHA wound solution, the best results for both safety and efficacy. Superiority driven by pH associated with optimum wound healing and a robust innate immunity system. So you're adding to your wound bed something that your body's already creating to fight off bacteria. That's it. Thank you very much.
Good afternoon again. Thank you so much. I hope you can all hear me all right. Amanda and Jeremy, thank you for that masterful presentation. Can you hear me okay, both of you? I believe a lot of questions have come in and we are short on time. So quickly ask the questions that you think are most important to answer following your session. Jeremy, you go first.
Thanks, Dr. D. I really want to know what patient feedback you and others maybe in the audience are getting regarding the use of pHA and any myths or concerns that we need to dispel.
Right. I think pHA has been in the North American market definitely for about 10 years or more now, and millions of bottles have been used on patients. Universally, patient feedback has been positive with respect to no stinging, no pain, and quality of life improvement is actually commented upon by them, particularly with respect to the odor removal. Now, that also has been published in peer-reviewed studies. So that is consistent feedback that we have obtained so far. Of course, they're pleased to see the wounds clean up, the necrotic tissue being removed mechanically, and so on and so forth. But quality of life improvement is one big thing that they comment on. Amanda, do you have any particular question?
I think the biggest one, it wasn't a question that necessarily I had, but a biggest one that I know that nurses always come to me with is about using VASH with antimicrobials. And I know that often I will tell nurses to pre-moisten an antimicrobial if the wound is dry, because especially in the community setting where we can't just choose a less absorbent product, sometimes we'll just say pre-moisten something. So just kind of your thoughts about VASH and antimicrobials.
Right, and I think that's an excellent question. The preservative in VASH is completely different, chemically speaking, and it's how it behaves with other materials. We do know that the hypochlorous acid preservative, and this is good news, it doesn't linger in the wound, it disappears very quickly. That is good news, because lingering preservatives in the wound, that definitely happens with things like hypochlorite or polyhexanide, results in cytotoxicity. And the good news with VASH is that once it has been applied, just like you said, by soaking for 5 to 10 minutes, if you just pat it dry at that point, you can apply any dressing that you want, including antimicrobial dressings. But do not pour VASH into antimicrobial dressings and then apply it to the wound, because you're going to have to throw away that dressing after soaking after 5 to 10 minutes. That doesn't make sense. Also, reaction of VASH with these antimicrobials is somewhat unpredictable. So soak it, pre-moisten gauze with VASH, soak it 5 to 10 minutes, wipe it firmly dry, pat it dry, all the VASH is gone, apply your favorite dressing. Thank you so much. I have some more questions that came in that I want to ask. Why not just use Dakins? Somebody asks. It's cheap, it kills germs. I will respond to it this way. It certainly saved lives in World War I, but that's a 100-year-old product, and it is almost 100% the cytotoxic sodium hypochlorite. It does kill germs, but it also sets your wound bed up with an alkaline pH. In healthy soldiers with imminent risk of gangrene, it probably saved lives. We got to believe what we read. But if Henry Dakins was alive today, he would agree with the science that exists, that it's very cytotoxic. And it's better to use the relative of hypochlorite, that is hypochlorous acid, which is far less cytotoxic. So these are all the reasons why you should not use Dakins. A high cytotoxicity. You chase your tails if you're killing germs, but also killing cells at the same time. Another question is regarding biofilms. Now, this is a very important topic because we know most chronic wounds have biofilms associated with them. In fact, there's a recent study showing that burn wounds within 2 or 3 days of the injury have biofilms associated with them. The question is VASH the best solution for biofilms? I'll give a very scientific answer to the question. The answer is you want to have many number of things in your toolkit. If you have a wound that has been neglected and is full of biofilm, and you know it has been neglected, nobody has debrided it, take your knife out, get rid of the biofilm using stainless steel. Following that, use of VASH, both to prevent biofilm formation as well as to get rid of biofilm that's 24 to 36 to 48 hours old is fine. And I think Jeremy presented that data against mafenide acetate that showed VASH is able to penetrate 24 to 48-hour-old biofilms. And then the last question I want to address from a chemistry perspective is why soak it for 5 to 10 minutes? Why not just spray it into the wound like you spray other cleansers? The reason is VASH has a very special formula, and clinical as well as preclinical lab studies show this, that if you want to mechanically remove germs and necrotic tissue, time matters. And Jeremy showed that in his biofilm slides. It takes about 3 to 10 minutes for you to get the clinical benefit that you deserve having paid for the product. Longer is probably not practical nor useful, but soaking with a pre-moistened gauze, there is plenty of clinical as well as robust laboratory evidence supporting that practice. Let me ask some more questions that are suitable to...
Is there any restrictions in the length of time you use that?
Sorry, could you repeat?
Is there any restrictions in the length of time you use VASH?
No, there isn't actually. I would like to say using it for 30 seconds is better than not using it at all.
I mean, as in how long, as in
No,
weeks, months? No.
Yes, there is none. In fact, this is very related to another question that just came in. Are there any contraindications to pHA? Now, most medical devices, and this is a medical device and not a drug, will have contraindications listed. We don't have any because there simply isn't any contraindications to pHA. And again, you got to remember the danger to the wound is from the preservative that is chosen. Hypochlorous acid is body's own preservative, so it is easily dealt with by the body as opposed to hypochlorite or pHMB or polyhexanide. So there's no time limitations on how long it can be used. Certainly, you guys have used it for months over the years.
I know. I was hoping you were going to say that there's no contraindications because I have been using it for months. And is it safe on pediatrics?
Yes, so there is plenty of evidence of its use on pediatric wounds, and there are separate presentations on this subject that's available on our website. And it is used in many children's hospitals, both here as well as in Canada, I believe. And because of its gentle nature, it's perfectly suitable for them. One question that just came up, does it expire and how should it be stored? It does not. Its shelf life is 18 months from the date of manufacturing, whether you open the bottle or don't open the bottle. Now, I hope you don't open a bottle and leave it on your shelf for 18 months. You're not recouping your investment in that case. But if you use it and cap it carefully, don't abuse the product. It is to be stored at room temperature. Don't freeze it, and so it's 18 months. That is the shelf life of the product. And the question is, does it come in a larger bottle that would last a few months? I think the 1 liter bottle will last 18 months if you want to make it last that long. But we don't make it in any larger sizes because it will be difficult to ship and all that. There were other clinical questions I want to ask Jeremy and then Amanda. The one question that came is, do you guys rinse the pHA after you soak it into the wound before you apply the dressing, or you just pat it dry? I think I answered it. What do you do, Amanda?
So, I mean, typically in the past, I was telling them to rinse it and rather than pat dry. And now I have changed, after kind of doing some research on this, I've changed it to pat, but I find that if I have tunnels where I know that potentially I can't get all of my pHA out and I want to put an antimicrobial in, and then I'll tell them to flush it with like a saline solution, just so that when I put in my antimicrobial, I'm not getting that pHA antimicrobial kind of intermixing.
Right. And then Jeremy, there's this question that I have no idea how to answer. It says, thank you, Jeremy. Now we need to figure out how to have quicker access to FNIHB. How to answer that, Jeremy?
Well, I would argue that NIHB is an excellent insurer for the comprehension of the coverage that's available, but the navigation can be very challenging. So I would say I agree with that. Let's hope that the future is bright in that respect, and that we're able to work with our partners in care to improve the systems that we're working within.
Okay, Amanda, question for you. I did see that you were treating some wounds with acetic acid, and then you moved to pHA. I'm assuming that you had stalled the wound, not you had stalled the wound, rather the wound had stalled because it was not going anywhere with acetic acid when it came to you, and then you...
Yeah, so it had come to me, and again, anytime that we see a Pseudomonas, I think that in the general kind of world population, we always were treating a Pseudomonas with acetic acid topically and then putting an antimicrobial on. So when she came to me, the acetic acid wasn't doing anything. She had continued to have issues with the Pseudomonas and extreme pain as well. So I was on the fence about kind of antibiotics. Oral antibiotics, correct me if I'm wrong, aren't really great for a Pseudomonas. So I made the switch, and I didn't kind of know how well it was going to manage it, but the nurse called me back in a couple of days and she said, hey, there's no more like symptoms of the Pseudomonas here. So I was impressed with that, because typically acetic acid was my go-to for a Pseudomonas.
Thank you so much. Final question, any research on development of hypochlorous acid resistant organisms? You know, I have looked, and believe it or not, they have found one organism in a poultry plant that was resistant to hypochlorous acid. But this is not a clinical isolate, and clinical isolates, 100% of what we have tested is susceptible to VASH, simply because it attacks the germs in so many ways. It's difficult for germs to mutate to build the defenses on that. And with that, I think we have come to an end of our question and answer session. I want to thank our panelists for providing these excellent cases and jumping in to answer the Q&A. One or more of them will be available in our booth to answer more questions from you one-on-one in the virtual booth. So we hope to see you there soon. Thank you so much and have a great day, everybody.